Senator Marshall.
Thank you, Chairman, and welcome to our our witnesses. My first question for Dr. Magee: how does the current oversight structure ensure that the organ procurement and transplantation network meets performance and patient standards?
So the OPTN is a public-private partnership with HRSA, and we look at making sure we're adherent to the principles underlined in NOTA, the final rule. We look at data regarding our outcomes, and the OPTN is also a small segment of this entire process that we're talking about. So we monitor policy, adherence to policy, and look for signals in those regards. So it's really based on our policy that we follow to make sure we're doing what is both in regulation and what we're responsible for.
Thank you. Let's go to Dr. Karp. You talked about ways HRSA can encourage innovation. Can you elaborate a little bit more on this, how the innovation would benefit patients?
Yeah, thank you. So this is the most exciting time in my lifetime in transplantation. It's really quite amazing what's going on. As these great advances come across the network and come across all of transplants to benefit the patients, there really needs to be centralized approaches to these. And I think donation after circulatory determination of death is a great example of that. So this is a new technology. We've been doing organs like this for a long time, but the new technology has been over the last 5 years, has really revolutionized transplantation. It's saved thousands of lives. At the moment, the technology, however, is being put out, and if it kind of each center has their own approach to this technology. And for us at Vanderbilt, we became the largest heart transplant center in the country because of use of this technology. But other groups around the country have not adopted the technology as quickly. And what I'd really like to see is a central mechanism by where when a new technology is brought forward, it's found to be useful, then it gets disseminated much more quickly across the network with a central oversight from HRSA as opposed to the way it's done now. And HRSA needs to take a much more active role in disseminating that technology.
Okay, thank you. Let's go back to Dr. Magee. Dr. Magee, the Midwest, where I'm from in Kansas, is famous that we have a higher organ donor rate than some the coasts do typically. And there's concern that too many of our organs are leaving the Midwest. What is the current policy on the location of the harvested organ versus the location where it's going to be used?
So certainly, the OPTN in the past, when transplantation started, 40 years ago, the confines of ischemic time, or how long the organ can be outside the body, limited a lot of it, and the sharing was much more local. As the methods have improved, we can both share more broadly and make things more fair across the country.
What do you mean by more fair? What does that mean?
Meaning standardizing waiting times, making sure that sicker
people
don't
So you're
die.
saying that more fair is to take organs from Kansas and transport them to some other state that's not doing a good job of out there encouraging donation?
No, I'm not saying that. I'm saying that if one of the principles of NOTA is that medical urgency should take place, medical urgency should be a priority. Second is geographic boundaries, to the extent possible, should not be a limiting factor. So our goal is really to increase and as you're pointing out, the rate of donation is also important to know, which is a tough thing to determine. We're looking into that, and as is the community, and making sure that we optimize the system as much as possible.
So that doesn't really sound fair to me. Dr. Karp, can you shed any light on your thoughts on, how do we're encouraging people to donate their organs, but frankly, they'd like them to stay locally when possible?
Yeah, so I agree with what you're saying. The major policy changes over the last few years have, in fact, moved organs from lower resource communities into higher resource communities. So places in the Deep South, places in rural areas, they tend to overall have a net export of organs now with the new policy changes. I think that's very, very difficult to justify. In addition to that, with these new policy changes around broader sharing, what's happened is that we have more organ discards, and I published about that. Other people have published about that, and it's dramatically increased costs. A liver can't save more than one life. And so this idea that somehow by moving this liver around the country or moving this organ around the country, that you're saving more people's lives is simply not true. And this is an area where I think the policy has been hijacked by special interests, and I think this is something that HRSA needs more oversight on. It's a complicated situation. I'm not going to tell you that I know exactly how this needs to end, but it is something that I believe has been put forward by special and passed by special interests.
Thank you so much, panel. Chairman, I yield back.